Bonjour à tous. Je vais enchaîner en anglais parce que je m'exprime mieux en anglais. Et puis la présentation, elle est rédigée en anglais également. So I'll continue this way. Thanks, Manjit, for that introduction. The second hat I wear, that second, and I'm not sure how to run. Is this how this works? No. See, I didn't take a course on running this. Anyway. Oh, you point. Yeah. I'm the executive director of the International Society for Telemedicine. Ah, wonderful. Okay. And the pointer? Oh, terrific. Thank you. Short course. Right. I was saying I was the executive director of the International Society for Telemedicine and eHealth. And when I was asked by Manjit to participate in this, I really don't have much expertise in the area of water and sanitation and indoor pollution. But when I do give my talks about ICT supporting health, some of the basic questions that come up all the time are, what's electronic health records got to do, telemedicine got to do, decision support systems, what do they have to do in health systems where people are dying from water and sanitation problems, food and nutrition issues, housing and shelter, et cetera, et cetera. And so, given that background, I've had to dig back into some of these areas to be able to justify why I think ICT is important to health systems. And examples like Margaret just mentioned, where the clean water business could be totally destroyed by transaction costs, involved in passing money around to facilitate that. So the society, as you see there, has as its mission two main points. One, sharing information and knowledge, and secondly, building capacity, making capacity available to countries. Where do I point this again? There we go. All right, so the outline of my talk, I'm going to talk a little bit about mortality and morbidity caused by water and sanitation and diarrheal diseases. A lot of it has been mentioned already. Chronic obstructive pulmonary disease, that's the sorts of diseases you get from indoor pollution. Then I want to talk a little bit about some interventions that a group called the H8 have been involved in. And since this is a conference organized by a knowledge sharing foundation, I thought I might bring some of our experience in WHO, in knowledge management, to bear on the discussions, and then we do some conclusion. Right. Okay. You've seen some of these figures. I just thought that rather than skip them, I just re-emphasize the figures are very much along the lines that Rabat mentioned this morning. 2.6 billion people without sanitation, and if we keep this up, the projections are that by 2015, which is the deadline for the MDGs, there'll be actually 2.7 billion people without adequate sanitation. And we know all the waterborne diseases. Startling figure, again, shocking figure, like your slide, Robert, 115,000 people die every hour from waterborne, water-related diseases on the African continent alone. Sanitation, I think Menahem showed this picture as well. These are the conditions, that lead to some of these, catastrophic figures of 1.5 million deaths, every year, mostly among the very young. And so this is what it contributes to attainment or lack of attainment of the MDG 4, which is child survival. Although there's been a decline of about 37% in child under 5 mortality in developing regions, many of the sub-regions, 5 of the 9, are not going to meet this particular Millennium Development Goal. We're in North Africa today, and I'm happy to announce that the Northern African region has already achieved the MDG 4. But for other parts of Africa, despite the major successes that have been recorded, we're still at 7.6 million children dying annually, down from 12 million, but it's still too large a number, to bear. So these are the contributors to, MDG4, a lot of neonatal deaths. The two areas that concern us primarily in this talk, pneumonia and diarrheal diseases. On this graph, they show 36% contribution to under 5 mortality, but actually that number has been reduced. It's an older graph. It's now around 29% only, but it's still 29% too many, particularly for conditions that are quite avoidable. And the other aspect of it, indoor pollution, air pollution, away from automobiles, if you will. Rabat again showed some of these figures. 3 billion, the figures we have, 3 billion users worldwide of solid fuels for cooking, for heating, for any number of household purposes. And because of that, so many deaths created by the environmentally unsafe conditions that derive from burning solid fuels. The numbers are there. Chronic obstructive pulmonary disease, 54%, 44% pneumonia, and lung cancer, 2% from this. And this is what we call the energy ladder. You see that at the bottom left is fuels that are derived from animal and vegetable wastes, all the way to the top right, to the highest levels of fuel, which are electricity. And it's very interesting to see that all these different aspects, we're talking about health, but if you pull the health thread, you pull in just about everything, because everything contributes to human health. And there's a slide that I'll show later which really emphasizes this. So this slide is to point out that we really do understand what the problem is. This is a classic pathway from a source through emission, through concentrations, etc., all the way down to what effects on health this chain can produce. Whether the effects are subclinical, very difficult to detect, or whether they cause morbidity or mortality. But we do really understand many of these chains from sources of pollution to effects on humans. But the problems remain, as we'll see. Fuel wood. This graph, I thought I couldn't resist it, because if you look at the graph on the right, it shows that women in Africa, and it's mostly women who are involved in this, they spend anywhere from half an hour a day to 4 hours a day in Niger fetching wood to cook for the day, every day, if they want to eat, that is. So very important problems linking all of these, sorry. Right, so indoor pollution, but it's not something that's limited to developing countries alone. This slide is included to show the dangers. Granted, they're not very elevated compared to other risks, but radon gas, which occurs quite naturally in decaying material in soils, causes 3 to 14% of lung cancers in developed countries who use, electricity and other forms of heating, which are not as dangerous as solid fuels. And the interesting thing is that there are no known thresholds of at what point does this sort of radon pollution begin to be harmful. What the studies show is that the risks are almost linear with the level of concentration or the level of exposure. So these are figures from WHO. These are not studies that I did on my own, but WHO announces all these different figures, and they're all available on the web. So the H8. The H8 is a group of health-related organizations, I guess patterned after the G8, why not? WHO, UNICEF, UNFPA, UNAIDS, the Global Fund for HIV, AIDS, TB, and malaria. Gavi is the Global Alliance for Vaccines and Immunization, the Gates Foundation, and the World Bank. In 2007, given that we were not making much progress, we still aren't making a whole lot of quick progress towards the health MDGs, this group decided to get together to collaborate further towards streamlining their operation to see how collectively they can do much better in terms of attaining the health MDGs. And they collectively have developed a number of interventions in the area of sanitation. For example, the latrine on the left, the VIP latrine, something that's been around for a long time. They know, such as examples as Manah mentioned earlier, water treatment solutions. Lots of the solutions have been developed by these, the H8, as you see. They've also come to the conclusion that if you invest $1 in improving sanitation, the returns are ninefold in terms of benefits, especially to the very young. So we do have some idea of what the problems are. We actually know what some of the solutions are. Drinking water, for example, WHO has published this guide on water treatment for small communities. And all that is available online. It's of interest to local governments, NGOs, primary healthcare workers, and others interested in that, based on a number of principles, understanding and getting commitment, buy-in from communities that are involved, building in monitoring and evaluation, and going on incremental, steady improvements in the situation. And so this is the virtuous cycle that WHO recommends in this publication, 6-step cycle for water safety. I'm not going to go through all of it. The experts in water safety are in the room, so you can talk to them about that. But basically, it involves getting communities to engage in the process, taking steps to identify the risk, and then incrementally improving those conditions and feeding back to monitor progress made and starting the whole cycle all over again. Very much like a plan, do, study, act cycle in many systems. In the area of radon gas, again, WHO has led work in developing a manual which pretty much outlines what needs to be done. The equipment there on the right that you can see is are detectors that you can buy, very much like smoke detectors in homes. These are available to be able to identify if the levels of radon gas, which, by the way, is odorless, it is colorless, but is available naturally, occurs quite naturally in many places. Fortunately, there's a very simple solution. If you open your windows, open your doors, aerate your home, you have less of a chance of getting radon, too much radon deposits in your system. Right. So I said earlier that I think it's really important when you talk about health not to leave it to doctors alone. That's the worst thing you can do when you're thinking about health. Particularly in developing countries, the pathways to good health, there are many more pathways to good health that have nothing to do with medicine. We've just talked about water and sanitation. As I mentioned earlier, we can talk about food and nutrition, housing and shelter, education. These are the pathways to good health. And the WHO commissioned a study called the Commission on Social Determinants of Health, who've put out a report. The commission focused on the non-medical contributors to good health, and their report is available online if you wish to look at it. But basically, they also focus on inequalities. Inequalities, one of their conclusions is that inequalities in health are killing people on a massive scale. Very powerful conclusion to reach. So they recommend 3 things: to improve the daily conditions in which people live, work, and play, because you can't just go into a health system and fix one item. You need to fix the entire environment in which they live. You need to tackle the inequitable distribution of power, wealth, and resources in the system. And like every WHO recommendation, you have to monitor and evaluate and see if you can make improvements. So what does all this mean? I've said that we understand pretty much what the problems are. We know some of the solutions. So I thought I'd bring in this slide. When we created the Knowledge Management Department at WHO, when I was still working there, we went around trying to preach the word, the truth, if you will, about knowledge management. What was it? This is only 2004, so quite recently. What was it? And we found it useful to look at this Chinese symbol for learning, which is made up of two parts. Oops. No. There we go. First part is to study, to acquire knowledge, and the second part, quite naturally, is the practice. So it is the combination of knowledge and practice that leads to learning. My wife, who's a teacher, quotes Confucius as saying, I hear and I forget, I see and I remember, I do and I understand, and those in medicine say, I teach and I understand even better. Hence, the medical paradigm, see one, do one, teach one. So, this is another slide that we used to show quite regularly. It's supposed to be amusing, but it underscores a very, very significant problem in knowledge management called the no-do gap. It is very clear. As far back as the 80s, Jim Grant, who was executive director of UNICEF, said 80% of the children who died during his tenure as executive director of UNICEF could have been saved because the knowledge to do so existed. It just wasn't applied where it was needed. And this misalignment between knowledge and the problems that knowledge is supposed to resolve, that's what we call the no-do gap of knowledge management. And I think water and sanitation, indoor pollution, the cases we're looking at here are classic examples. We pretty much know what needs to be done, but we are not able to do them. So what can we do? Well, these are the risk factors. Again, part of the knowledge. And I'm leading to a point here. You see, there are 19 of them. I'm not going to go through them one by one, but they have to do with the 2 points we're considering here: water and sanitation and indoor pollution. So these indicate the gains that we can make in life expectancy if we can eliminate these, or the reductions in mortality, if we can eliminate some of these risks from our lives, we as individuals. The burden of disease, same idea. You can reduce these quite significantly if you can eliminate some of these risk factors. And in terms of geographic distribution, again, Africa seems to be leading in the wrong things. Margaret Chan, when she took over as WHO Director General, said she wanted to be judged by two benchmarks: what her tenure did for health in Africa and the health of women. We're still a long way from seeing major successes in both areas. Hang on. There we go. So those are some of the gains we can produce in life expectancy. More than 10 years if we eliminate, these 19 major risk factors. So, what is the lesson from all of this? Well, as I've said, we understand pretty much what the problems are, but the major challenge that we face is the no-do gap. And that underscores a major fundamental question in my view, and perhaps as a foundation, the Knowledge Sharing Foundation should perhaps look into this. And that fundamental question is this: whether there is greater value not in developing new knowledge, but investing more in learning how to apply the wealth of knowledge which we already have to the problems that we're facing. It's a very fundamental challenge, and I think the foundation is well placed to institute this paradigm shift from knowledge creation to knowledge translation, to get more out of what we already know, even as we try to push the frontiers of our knowledge beyond their current boundaries. And the last bullet there refers to the role of individuals. I think behavior change communications, those risk factors are really up to you. There's only so much that governments can do. And I insist that the largest resource in the health system is people. Yet it's often the most underlooked. We all look to service providers, we look to governments, we look to institutions, but individual responsibility can go a long way towards mitigating the effects of some of these risks, which are environmental in nature, but personal behavior, in my view, can help reduce the risk of morbidity and mortality and increase the quality of people's lives. I thank you for your attention.